management of the patient we sit, and where we take the baton from the clinician and then we pass it on after we've made our observation back to the clinician and make recommendations. So that is why we have to know exactly what we're doing for each patient. It should not be just a description of what we're seeing. We should know what we're saying and how it's going to affect how the patient is going to get treated. So I'm going to speak a few words about that first. Then I'm going to move on to describing radiological anatomy of the prostate. Then I'm going to move on to pathology of the prostate, which is prostate cancer, and the pyrite system. I hope majority of the people are acquainted with it. Pyrite system. So now,
yes.
Fine. I'm sorry if I overestimate or underestimate करता हूँ. I apologize in advance because मेरा काफी अच्छे से interaction नहीं है. So just correct me. अगर आपको लगता है you need more information, just ask me. Okay, guys, Usman, I don't know. Can you elaborate? Or if you think it's too basic for you, again, you can just Sarah, you can maybe
yes,
sort of
there are
moderate.
questions in a chat session, and I'm going to ask you.
I think it might be easier. I mean, there's like 100 plus participants.
Yes,
chat
there are
session which I
133 participants.
follow na kar sakun, but you feel free to unmute people where you feel
Yes,
it's relevant, and they can put the question to me. I think you can be a moderator, right? So pyrite system is basically a bit like breast. Pyrite system is designed to assign a risk grade to what we see on the prostate scan and so on. Or अगर end में time बचा, if any of us is not too tired from the long session, then maybe you can look at a few cases. I'm sure आप लोग enthusiastic होंगे और रात के 12 भी बजे, तो I'm sure I remember from my own days कि thirst इतनी होती थी कि I'm sure nobody will say yes. लेकिन हो सकता है मैं थक चुका था. Anyway, so moving on. So why do we do this? So rationale. So a few definitions first. Few things we must know. Look, guys, I'm assuming that you're preparing for FCPS exams, and hopefully you're gonna go into practice and you're gonna be encountering prostate MRI, right? And you will be working with urologists in devising a treatment plan for the people who have MR. So there are a few minimums that you must know as practicing radiologists, and also for the sake of your exam, a few things. One, these are three critical keywords in prostate imaging. Multiparametric MR. ये बड़ा common use है. दूसरा, what is clinically significant cancer? और तीसरी phrase है active surveillance in prostate. Multiparametric MRI, simply as its name says, funnily, I mean every MRI is multiparametric. आपका T2-weighted imaging होती है, D1, diffusion, contrast. So yeah, so it's a bit of a you could argue कि यार सीधी सी बात है, MRI होता ही multiparametric है. I think generally when you include dynamic post-contrast imaging as a sequence to your MRI protocol, it is called usually multiparametric MRI. What is dynamic post-contrast imaging? Typically, we give contrast on a T1 weighted sequence. We inject gadolinium and then we acquire images. That's called, that's a post-contrast scan. It is called dynamic when you repeat the acquisition after every 13 to 20 second interval from the point of injecting the contrast, and then you keep acquiring these sequences up to 3 to 4 minutes. And then you end up with 20 series. Okay, so that is dynamic. Breast में भी चलता है, और आपको curves मिलते हैं, enhancement curves मिलते हैं, और आप fancy चीजें करते हैं. Let me give you broad generalization right off the bat. In clinical practice, curves को मेरे colleagues नहीं देखते. मैं UK में 10 साल से जहाँ भी काम किया, कई बड़े centers of excellence है, इधर trend कम है curves को देखने का. कई लोग बहुत शौकीन है, लेकिन usually we eyeball just by looking at the dynamic sequence, a lot you can get a lot out of it. So अगर because getting the formal curves, you have to sit on a workstation, spend extra time. If you don't have time, then I can assure you can still make a decent diagnosis, about what's going on dynamically just by looking at the scans. So requirement do a multi-parametric MR, you need at least two.
Recording in progress.
मैं आपको बाद में दिखाऊंगा एक पूरा एक टेम्पलेट जिसमें सारे मैंने सीक्वेंसेस अरेंज किए होंगे and then I'll talk you through how I analyze a typical scan in my day-to-day practice. Clinically significant cancer. So you must know that in older men after 60, 70, small foci of prostate cancer are not extremely uncommon. A lot of men have it. And interestingly, they will die of other reasons before that cancer kills them anyway. So, just because prostate
Recording in progress.
There's a slight difference. Active surveillance, which I'm forgetting a little bit, but you could look that up as well. Active surveillance, there is something to do with being active. So basically, so this whole thing of doing annual MR and annual PSA assay is called active surveillance. Sorry, not annual surveillance. Okay. So typically the patient comes to the urologist or to the GP and, complains of LUTS, lower urinary tract symptoms, dribbling, and hesitancy, frequency of maturation, that sort of thing. They go to the urologist who examines them, they put a finger rectally and they examine the prostate. They find out, okay, that prostate is enlarged. The man is a bit old. Sometimes the clinician will actually will raise the possibility this man may have cancer. A lot of times in these adults, the urologist will then order PSA, prostate specific antigen assay, which is a blood marker of prostate cancer, and there is a sort of a vague threshold. Okay, it's not a sharp threshold. You can't say, okay, अगर आपका 2 nanogram per mil से ज़्यादा है PSA, तो उसको cancer है कम. It's not a very tight threshold. They look at the PSA, they look at the man's age, the symptoms, and trust to trust variability of where they become suspicious. In some places at 2 nanograms and above, for example, they will trigger the investigation for possible prostate cancer. At a very low PSA, they may just say, go home, just do conservative treatment for your LUTS and, come back in a year and we'll do your PSA again. So once a sort of a clinical constellation of symptoms, signs, and laboratory markers justifies it, the urologist puts the patient through a prostate cancer investigation stream, which includes multiparametric MRI, biopsy, and based on how suspicious they are, they may add on more more elaborate tests such as a bone scan, for example, if the PS is really high and they're worried, okay, ye pehli metastasize kar gaya hua, and prostate cancer loves to go to the bone. They may also order a bone scan. और आजकल एक नया टेस्ट कुछ सालों से बहुत पॉपुलर हुआ है, ये PSMA PET है, prostate specific membrane antigen. It's highly sensitive. It's a bit like FDG PET. You can read more about it. It's very sensitive to detecting prostate cancer in the whole body. It's a PET scan. Okay. Right, so these are the tests. I'll quickly say a few things about active surveillance, just to give you a little more information about, what we are doing with these people, So for example, this is from Prostate Cancer UK website. This is a flowchart that, they recommend to urologists. इसके अंदर जो nutshell में मैं कहना चाहूँगा वो ये है कि, they do a risk stratification, okay? Every patient who has a diagnosed prostate cancer is risk stratified. Okay, is he intermediate risk of disease progression, or is he low risk, or is he high risk? Generally speaking, if they consider somebody, and I apologize if the background noise of this lawnmower is annoying you, I can't do anything about it. आवाज तो आ रही है सबको adequately?
Yes, sir. कोई हमें extra आवाज नहीं आ रही।
मुझे आपकी थोड़ी कम आ रही है. Let me increase the volume. I set up.
Still well audible. कोई issue नहीं आ रहा।
Sorry, can you hear me?
Yes, sir.
मैं तो डेफ हो रहा हूँ, ये किसी बंदे ने अपनी घास काटना शुरू कर दी. Right. So low risk localized. So basically they can. So this is basically it's going to tell you how we work. It's a multidisciplinary thing. Staging जो है prostate cancer की, ये prostate MRI कर रहा है, PSA जो है ये blood test कर रहा है, Gleason score biopsy के pathologist कर रहा है, और ये सारी चीजें देख रहा है urologist. Right? So the urologist gets back the prostate MRI report, the lab report, and he gets back the pathology results, and he risk stratifies them. And if they think, okay, this guy is at fairly low risk of disease progression, then they will consider active surveillance, and they do annual multiparametric MRI. But if they think, the Gleason score is 7, PS is fairly high, clinically, he's got, a fairly large amount of prostate cancer inside his gland, then they might go on for other things like surgery or radiation, which I'll speak of next. Okay, so you can look at this in more detail. The main reason I'm presenting these slides here is to give you the impression that imaging of prostate cancer is not something a radiologist does in isolation and just puts out a report. It is something which is multidisciplinary. It involves a consultation between a radiologist, the surgeon, and a pathologist, okay? And then the surgeon has the final say in whether to operate or to radiate, or if the patient is, advanced or is not fit for surgery, then to just give them hormonal treatment. What hormonal treatment does is it lowers, it lowers basically the rate of progression of cancer, okay? और radiotherapy is very popular these days. UK में ज़्यादा trend है radiation देने का. USA में surgery करके they just take out the whole prostate. Both treatments in terms of outcome, survival outcome, are very close in terms of survival outcome with each other. UK में argument ये है कि अगर आप prostate निकाल देते हैं, sometimes these people have erectile dysfunction afterwards, and morbidities like that. That's the argument in UK why we do radiation more often here. But survival-wise, they're quite close. A few more words about the great things about MR. I think you guys should probably have a look again. I'm not going to go into too much detail on this slide. There's a lot of already discuss anyway. But there was a time when there was question whether MR really helps that much or not, because surgical assessment, PSA, bone scan, they together actually provided a fair amount of information. For example, if a PSA is really low and the prostate, doesn't feel very bad on surgical examination, there may be an argument that a lot of these people will not require surgery eventually. So why are we even doing an MR? So there was a large trial, a very large trial was, conducted, and that trial concluded that no, doing an MRI will benefit people in terms of survival. So now, prostate MRI is very much a part of management of prostate cancer. These are some of the benefits of doing an MR. Some of them being कि अगर आपका MRI is normal, so that is a very, very reassuring sign that this patient does not have, is probably not gonna ever need surgery. So there are things like this that are really beneficial. And also, if your biopsy is showing cancer on one side and prostate MR is showing cancer on another side, then, it allows the surgeon to do another biopsy because the first biopsy may have missed the cancer because of sampling error. So, it has these benefits in sort of correctly risk assessing people. Okay. मैं 2 minute का breather लूंगा. Does anybody have any questions?
Sir, there wasn't any question, but sir, there's an issue. Everybody wants if you could just change the view to a landscape because we can see this writing very small, so it's probably ineligible for.
Oh, really? अच्छा?
Yes, sir.
मेरी तो पूरी स्क्रीन पे राइटिंग आ रही है. क्या लोग क्या फोन टैबलेट फोन पे देख रहे हैं ये?
नहीं सर, सब लैपटॉप पे देख रहे हैं सर कि लैंडस्केप मोड पे नहीं आ रहा.
Okay. Right. मैं बाद में स्लाइड्स आपको फॉरवर्ड कर दूंगा. लेकिन मैं ये कहना चाहूँगा कि yeah, I get this slide probably बहुत छोटी, लेकिन ये स्लाइड्स में बहुत ज़्यादा information नहीं है. You're not going to miss too much out if you're not able to see the slides. But I'll also email the slides, to Dr. Kaz, and you can look at them in your convenience. Okay. So this is a slide about prostate anatomy, gross anatomy of the prostate. Imaging anatomy की बात करते हैं. It's very important to know, obviously. ये Wikipedia में बड़ी अच्छा picture है इसका. The prostate gland is pyramid shaped. Now I'm gonna just show the MR and speak with reference to it. ये सॉफ्टवेयर स्लाइसर 3D ये मैं यूज करता हूँ. It's not ideal. It crashes a lot. It has lots of bugs, but it's a good. It has its benefits. You can show study cases. It's like a DICOM viewer with the ability to also display JPEG images and whatnot. Okay. So ये picture में ज़बरदस्त है. It's a pyramid-shaped structure. ये sagittal view है T2 weightage, ये axial view है T2 weighted, and this is a coronal sequence T2 weighted. Okay, मैं इनको zoom in कर देता हूँ ताकि और बड़ा नजर आए. Okay. Please let me know now if it is too small, and then I'll have to switch to a single view because it's important that you are able to clearly see this. Sarah?
So everybody thinks it's just fine. So okay,
fine. Okay, so it's a pyramid structure, pyramid-shaped organ just below the neck of the gallbladder here, and it ends above the urogenital diaphragm, which is that muscular sheet that separates the perineum from the pelvis. In between them lies the prostate gland. The prostate gland itself, So, it has these lateral surfaces, a posterior surface that abuts the rectum, lateral surfaces, and the anterior surface. Importantly, the prostate is surrounded by a pseudocapsule, which is just a thickening of fibromuscular tissue. It's not a true capsule. Pseudocapsule, which is deficient anteriorly. Very low signal band. This is actually not a part of the capsule anterior. This is known as the anterior fibromuscular stroma. Histologically, अगर आप definitions पढ़ेंगे तो funnily enough, जो मुझे definitions मिली हैं, they say that the pseudocapsule is fibromuscular tissue and anterior stroma is also fibromuscular tissue. So it's funny to say that they are separate structures, but actually you can actually see that on MR, this is a bit thicker, darker, and the anterior fibromuscular stroma is considered part of the gland, whereas this thin black line around the gland is called the capsule. Okay. So this is the prostate capsule on the sagittal as well, and you can see that in the midline, this bit is deficient, and it's called the stroma. Right above the prostate gland, there are these paired tubular structures, oil tubular structures known as the seminal vesicles. These store the seminal fluid, which is high fructose content fluid. The seminal vesicles converge into the prostatic urethra, these two ductal structures known as the ejaculatory duct, and they open upon a depression of the prostatic urethra, which is known as the verumontanum, after joining the vas deferens, the ductus deferens. Okay, so that's how the seminal vesicles work. And right posterolaterally to the prostate gland. Now, if you go back here, so you're going to see some tubular structures posterolaterally. So these are the neurovascular bundles. Okay, so important to know these because in reference to a cancer, if you find a cancer here, the surgeon is interested to know if the cancer is involving these areas. That has implications for the patient. So neurovascular bundles posterolaterally, 5 to 7 o'clock on this side. 5 to 7 o'clock on each side are approximately where the neurovascular bundles are. The other surgically significant landmark to identify is the membranous urethra, which is obviously it's the urethra as it exits the prostate gland. So this is the lowermost apex of the prostate gland. Right below that, the urethra pierces the urogenital diaphragm, and it joins the penis. And this is right here is the pulp of the penis. So this section of the urethra, you have to measure it. Okay, when you find a cancer, you measure it. You measure the proximity of cancer with it, and the length of the membranous urethra. So this again, involvement of neurovascular bundles, length of the membranous urethra has a role with continence following surgery. So surgeons are sometimes interested in knowing these two things. Right. So I'll move on to zones of the prostate. So you've got the transitional zone, peripheral zone, central zone, and anterior fibromuscular stroma. Fibromuscular stroma I've already discussed. The transitional zone of the prostate is part of the prostate that is on the sides and anterior to the prostatic urethra, and that's also the part of the prostate that develops BPH. And when it develops BPH, it increases in size. It compresses the peripheral zone, which is like a cup around the transitional zone. It encapsulates the transitional zone. So as the transitional zone grows because of glandular hypertrophy, the peripheral zone, it thins out. Okay. And interestingly, that's also where majority of the cancer occurs. About 70% of the prostate cancer occurs in the peripheral zone. So in a lot of men who have a lot of BPH, they have a very large prostate, they have a very thin-looking peripheral zone. A lot of times we can't see cancer in that because it's so thinned out. Then the central zone is that part of the gland which is directly behind the transitional zone. And a very simple way to remember the central zone is that it is prostatic tissue that forms a sleeve around the ejaculatory ducts as they converge upon the prostatic urethra. And the anterior fibromuscular stroma I've already shown you. I'll show you a couple of images to drive this home, and then I'll go back to the MRI, and then I'll show it on the scan. Okay. So this is a sagittal slice. You can see the prostatic urethra, ejaculatory duct. It's a pair, one on each side, coming down from the seminal vesicles, converging upon the verumontanum. This is the transitional zone. So you can see that it kind of is more interior and on the sides of the prostatic urethra. And in a patient with BPH, it's very easy to identify. I'll show you. So remember, the transitional zone is around the urethra. peripheral zone is literally coming outside, and the central zone is that inverted teardrop shaped structure, which envelops the ejaculatory ducts, and it converges down like this. A peripheral zone is the bit of the prostate that cups it, and this is the anterior fibromuscular stroma, which is poor in glandular elements, more fibromuscular tissue. Right. So let's go back to the scan and identify these. Okay. So this prostatic urethra. Okay. So you can see here. These are the seminal vesicles, ejaculatory ducts. ये urethra नजर आ रही है, इसके sides पे ये ejaculatory ducts हैं, और there you go, merge हो गया. और ये prostatic urethra है, okay? और ये उसका थोड़ा सा muscle है उसके इर्द गिर्द. And then as you go down, you can see that all this dark area anterior to it, this is all the transitional zone, okay? So go up and down. All of this is transitional zone, and you can see it has a slightly different texture. It has more sort of cystic spaces. That's because BPH is developing. I've got a case of a younger man. He has very little BPH, and it'll help you identify how it looks in health, and as we age, how the prostate changes in its appearance. And then this bit is the central zone. So it's it's not easy to differentiate transitional zone from central zone very well on the axial slices. But just to remember, like I said, the bit that surrounds the ejaculatory ducts is the central zone. It's easy to see on the coronal slices, actually. So this again, seminal vesicles, ejaculatory ducts, or this inverted teardrop shape, इसको Mickey Mouse ear भी लोग कहते हैं papers में, and that is the central zone. So it's not a very big part of the gland. The important thing to remember is to not confuse it for cancer, because cancer will look low signal on T2-weighted imaging. This is T2-weighted imaging. It will also look low signal on the ADC map, right? So if you're looking at it, especially if you're a beginner practicing radiologist, you're looking at the gland, you're thinking, okay, cancer, then you have to be very wary that as you approach the base of the prostate gland near the seminal vesicles, you're going to see this dark signal of the central zone. So do not confuse it with cancer. Sometimes another mimicker of cancer is you see this dark signal around the transitional zone. So this is called the surgical capsule. So when people, when the surgeon operates on people for BPH, they scoop this out. They scoop out the transitional zone with the help of the surgical capsule. So sometimes you can get focal thickening here of the surgical capsule, and it looks a bit like this in signal, except that it is down here. And that can also mimic cancer. So there's a paper in AJR that talks about pitfalls in prostate cancer imaging. So it's a good read. Right, so I mentioned prostatic urethra, its relationship with the central zone. I've described the transitional zone. All of this white area, very nicely outlined around it, is the peripheral zone. And remember, 70% cancer in the peripheral zone, about 25% in the transitional zone. And this most darkest region at the anterior-most aspect of the prostate gland is the fibromuscular stroma. Look at it well, because you don't want to call this cancer. Okay, that's also a mistake. Some people have it slightly asymmetric looking, a bit thicker, because this guy's got a very symmetric anterior stroma, right? Left sides are both very similar. It's difficult to confuse this for cancer, but it's a mistake you can make if you're not aware of how it looks and how it varies from person to person. You might, mistake it for cancer. So 5% of cancers can occur in the anterior stroma. Okay. Let's see what we've got next. Right, so before I move on to the scheme of how I interpret prostate MR, does anybody want to have a question, Sarah?
So there's one question. Can you kindly point the transition zone again?
Right. On the axial series, the transitional zone is anterior and lateral to the urethra. So if you identify this bright structure going through the center of the gland, this is the urethra, right? Same thing on coronal, this line down. And I'll see if, yeah, sagittal में ये पकड़ा नहीं गया urethra exact midline में शायद slice नहीं है. So the dark structure, the dark tissue anterior to the urethra is the transitional zone. और sagittal पे भी ये बड़ा clearly दिखता है. All of this. ये देखें अब येलो, अगर मैं इसको वापस लेके जाऊं स्लाइड शो में, इस इमेज को ज़हन में रखें, okay, and look how translucently the urethra is showing through. अब वापस स्कैन पे आए तो ये इसके एनालिगस इमेज है, ये स्ट्रक्चर जो है ना, this is all of this is the transitional zone, okay? और ये इधर अच्छी नजर नहीं आ रही इस केस में sagittal में, but this is where the urethra is, right? Does that help?
Sir, we students want to see the central zone again as well.
Okay. Central zone.
Especially on the axial groups.
Axial पे पता है क्या है? The thing is axial, you just gotta look at the base of the gland. You know, you got the seminal vesicles here, and you come down, and that's it. You see this very dark bit, and you can sort of, you know, that is the central zone. And you keep coming down, and it merges with the transitional zone, and you can't differentiate. Okay? So this very dark bit, central zone, this is this is the ejaculatory duct, anteriorly, central zone, come down, come down, come down. जैसे urethra form हो गई है, right? जैसे ejaculatory ducts गायब हो गई हैं, central zone is gone. Now it's all transitional zone, right? इसको आप इस पे भी देखने की कोशिश करते हैं. ये central zone है, laterally, right? You see this is inverted, इधर भी inverted teardrop है, okay? Medial to it is the ejaculatory ducts. इसमें catch नहीं, size thickness may be too high, लेकिन ये ejaculatory duct है. और further medially near midline आप आएंगे, तो you know that is going to be the transition. Central zone is like this, bilobed sort of Mickey Mouse hair कह रहे हैं इसको, right? ये central zone जैसे आप transitional zone है, ये पीछे से आके ejaculatory ducts के साथ साथ converge करता है urethra. इसके आगे सारा transitional zone. Okay. Generally speaking, interested in detecting cancer.
Recording in progress.
He also has cancer actually, but I don't want to confuse you guys too much. ये जो black dot है ये cancer पड़ा हुआ है. ये एक second dot है इधर, ये भी cancer है. लेकिन if you ignore cancer, it's a very good example to teach anatomy. Yeah. Okay.
Next question is, what is the criteria to call a prostate enlarged on MRI?
Generally, 20 cc and below is going to be small. Is a normal size. That's what I would say. अगर मेरी practice में मैं बहुत ज़्यादा worry नहीं करता enlargement वगैरह पे, क्योंकि you know अगर एक बंदा है उसका 30 cc का prostate है और आप सोच रहे हैं कि you know what यार ये थोड़ा सा बड़ा लग रहा है, लेकिन बंदा asymptomatic है तो you know you could say mild hypertrophy. अगर 20 का है, you would definitely not call it enlarged.
30 plus, it's reasonable to call it, yeah, it's enlarged. The other thing is obviously अगर इस तरह से glandular tissue है नजर आ रहा है उसमें develop हुआ हुआ, तो ये short enlarged है, ये BPHS बंदे को. और अगर सारा एक जैसे ही है सिग्नल, जो मेरे पास एग्जांपल है मैं दिखा दूंगा, तो आप कहेंगे कि ये enlarged नहीं. सेकंड थिंग, एक चीज इसमें लोग बहुत गलती करते हैं, वो है एक्चुअली वॉल्यूम कैसे मेजर करनी. तो इसका तकरीबन एक ही बेस्ट तरीका है. मोस्ट ऑफ द अदर वेज टू मेजर द वॉल्यूम ऑफ द प्रोस्टेट आर रॉन्ग. लेट्स सी, ये आप रट लें इसको. Sagittal and axial series are best to measure the prostate. You should get the width of the prostate on the axial series, and the other two orthogonal measurements on the sagittal series. Don't do it any other way. Don't look at the coronal. Don't try to measure two measurements on the axial, क्योंकि वो axis थोड़ा खराब हो जाता है, orthogonal नहीं है. So I always try to do this. कि मैं आइडेंटिफाई करता हूँ कि इसकी एपेक्स का एंड हो रहा है, डायफ्राम कहाँ आ रहा है और ब्लैडर नेक कहाँ पे. यहाँ पे थोड़ी बहुत गलती हो जाती है. Sometimes you think the gland is up to there. Some people say यार ये तो सारा स्ट्रोमा. उन्नीस बीस की गलती हो जाती है. It's fine. And then you get the axial slice where the prostate is its widest, and then you also find a sagittal slice where it is at its widest. And then, let's see if I can draw two more lines. अब आप कुछ लोग यहाँ पे measure करेंगे, कुछ यहाँ पे करेंगे. You can look up literature and see what's the best, क्योंकि eventually तो pathology to roughly below where it's maximum. You have to remember that it's not, you don't have a measure, you don't have a formula that is designed साइट यूज करता है, तो इसमें ऑलरेडी एरर है, क्योंकि ज़्यादा आपके प्रोस्टेट की शेप स्फेरॉइड है. सो it doesn't, I don't think it matters कि कौन थोड़ा सा ऊपर का, बिल्कुल एपेक्स पे ना मेजर कर दें, क्योंकि वो फिर बिल्कुल गलत रीडिंग है. So I roughly go just a little below where it is at its base, and there I get this measurement, and I align it at a right angle to the urethra. So the urethra, notice it's going through like this. Okay, I hope this is clear to everyone कि urethra यूं नहीं जा रहा, यूं भी नहीं जा रहा, it's oblique, right?
Yes.
और ये आपका जो है ना, ये plane होगा फिर. Okay, so ये cross, this has to be a perfect cross. और यहाँ पे जो भी आप width लेंगे ना, so this is going to be a 3 perpendicular measurement. Most of the other ways you measure it, you're going to lose orthogonality. So that's why I say just do it this way. Okay, do all these three, multiply them with each other, then multiply by 0.53. I think it's zero. Some people measure 0.52, sometimes 0.53. It's not a big difference. And then you've got the volume of the prostate. There is something known as PSA density. It's a very clinically relevant marker. You divide the PSA level by the volume of the prostate, and you should mention that on your report as well. It's called PSA density. Read more about it. Okay, I'm going to move on. Okay, so before, shall we say? Okay, I want to say a few things about PIRADS classification. Okay, I just want to know, Sarah, how well do all people know everything about PIRADS? How much detail do I need to go about into it?
Sir, when we were preparing for FCPS, we just had a very superficial knowledge about PIRADS. So I am sure most of the participants know equal to me. So I would like if you just elaborate a little.
That means another session. Right. A radiology assistant is a fantastic website. PIRADS yeah, I love that website. It gives you, not just theory, but very clinically relevant information. I still use it, and I really like it. PIRADS version 2 चल रहा है आजकल. All you guys know about it?
sir.
Okay, then it's time to upgrade. कुछ साल से Pyrex 2 आया हुआ है और मैं बहुत बड़ा proponent हूँ Pyrex version 2 का. Main difference ये है कि पुराना जो Pyrex था उसमें T2 weighted imaging was the central point. अगर पाकिस्तान में अभी भी diffusion weighted MRI body DWI इतना popular नहीं हुआ तो I guess it's okay to use Pyrex version 1. जब मैं शौका खाना में ट्रेनिंग खत्म कर रहा था तो हम प्रोस्टेट में हमने शुरू कर दिया था डिफ्यूजन करना. बाकी we were still trying to develop things. So if by now I hope it's widely available, widely done. But if not, then even in England some doctors still use T2 weighted imaging axial instead of diffusion weighted imaging. But what I'm going to teach
is being used.
Very good. Very happy to hear that. I'm a big fan of diffusion weighted imaging. Liver में भी हो रही है diffusion.
The liver में तो नहीं देखी लेकिन सर breast और इसमें हो रही है prostate.
Fine. Well, that's fantastic. Okay, so that means we should all forget about version 1 and only look at version 2. मेरी practice में मैंने देखा कि version 2, which is slightly confusing if you're a newcomer, so do please go home and read a lot about this. After I finish today, there are likely to be a lot of questions in your minds, and so you must go and read about it. It's not something you can become an expert in one session, so it'll be a taster. You'll have to read a lot, you'll have to look at a lot of examples, from internet, from your practice. And even then, it's a difficult skill to acquire. So don't worry, eventually I would say it's a realistic goal if you're training for FCPS or if you're a beginning radiologist, just ending your training. I would forgive somebody who just finished training and could only pick up gross obvious cancer in the prostate gland. Fine dots and blobs, they confuse a lot of us, even people who are, fairly down, the road in their clinical practice. So don't be just if you miss, just like a man cancer दिखाते, if you miscall it, somebody says, oh, ये तो Pyrex 2 है, someone says Pyrex 4 है. There is be some variation. So, you can be a little lenient with yourself with Pyrex. So that's it. So Pyrex version 2 is, okay, you've seen.
Recording in progress.
Pyrex on T2 weighted imaging. For peripheral zone, you do Pyrex scoring from diffusion weighted imaging. Okay. The other important thing to remember, for Pyrex 3 indeterminate, you call on one additional sequence to help you, to call it Pyrex 4, because we don't want to leave things indeterminate. We want to be definitive, benign, or malignant. Pyrex 3 is not an amazing category because it says, in other words, I don't know exactly what this is. You want to be able to help the clinician as much as you can by saying it's either benign or it's cancer. So when you encounter a Pyrex 3 lesion, you use an additional sequence. In case of the peripheral zone, that additional sequence is dynamic contrast MRI. In case of transitional zone, which you interpreted using T2 weighted imaging, that additional zone is diffusion weighted imaging. Okay, so bear that in mind. Actually, this picture may be... Sorry. Right. So, इस में भी दिखाया हुआ है कि if you have a Pyrex 3 lesion on peripheral zone using diffusion weighted imaging and dynamic
Recording in progress.
No, sir.
Right. So I'm going to show you how I interpret prostate. So I'm sitting, starting my day with reporting MR prostate, and this is how I. Yeah, it does this sometimes. That's what I don't like about this software. Crashes and does stupid things. Sorry, I'm just going to load it again. It should take no more than a minute. ये ब्रिटिश लोगों को घास काटने का बहुत शौक है। तेरे मेरे भी एक दोस्त ने घास काटना शुरू कर दी तो उसकी फिर नींद जो होगी मैंने स्प्लिटर हो गया उसको। आदत नहीं होती तो वो 8 घंटे खड़ा रहा तो शाम को उसका स्प्लिटर हो गया। फिर इंग्लैंड आना और घास काटनी तो पीछे शुरू कर दें फिर माली वगैरह का ट्रेंड नहीं होता। तो हम देसी लोग हम फिर भी इधर आए कर लेते हैं। एक और देसी बंदा मैं ढूंढा हुआ सिख है वो आके काट जाते घास। Right. Right. So this is how I work. Okay. Remember, I one way did imaging, and I never thought prostate. Switch to single view so that everything is big and obviously. So the sequences that I use in my day-to-day practice, D1 weighted imaging, standard D1. You can see the fat; it is bright, so it's non-fat suppressed. Then there's an axial T2, high resolution. You see that the periphery of the anatomy of the person is cropped. You can't, like as opposed to D1, you can see pretty big field of view. Okay, let's get that. Try and move this. Okay, so you can see that that's a pretty big. You see how wide these guys are quite. Ideally, if you work closely with an MR radiographer, what I don't like is, seeing all this black stuff outside. This is unnecessary. If they can, prevent artifact, or if they can preserve enough signal, you should have a small field of view, just touching the skin, not get too much black area. But sometimes radiographers they get lazy and they just don't bother reducing the field of view to give us better spatial resolution. So, but you'll see that this is a much smaller field of view, right? So that's high res, short field of view, axial T2 weighted imaging. This is a wide field of view, sagittal T2 weighted imaging. Iska role is mainly to measure the size of the prostate. That's it. I typically do not look at it again once I've measured the gland. I forget about it. Then you've got the coronal T2 weighted imaging. It's a very critical sequence. A lot of times you will find, it allows you to look at the entire peripheral zone together like this. Because you see, the peripheral zone is mostly, it's actually a slab, it's like a vertical slab of tissue, right? So to look at it on an axial sequence, which is obviously the first thing to do, you actually have to go through a lot of images. You see, I start here at the base, tuck, going down, right, all the way down. But if you're looking at the coronal, you can see the whole of the peripheral zone in a matter of 3 to 4 images. You see, that's it. It's gone upside laterally here. So mainly I find it, and see how well it is showing you these striations. So these are Barrett's 2 linear signal lesions. This is normal striations you'll see in the prostate. This is not benign. It's not significant. So it shows you very well. And if there's a lesion, it shows up really well in the peripheral zone, okay, on this sequence. So I highly recommend making a habit of looking at the coronal series. Then this is the diffusion-weighted imaging series. We acquire typically, at B50, and then there is several B strengths, I forget, but we go from B50 up to B1400. If you have a very modern, very powerful scanner, they may go up to 2000. B2000, but in my practice, I find B1400, the highest strength gradient, is well sufficient for most clinical applications. B2000 if you don't have like state-of-the-art equipment, you just confuse yourself unfortunately, because you lose so much signal when you increase the B value of diffusion-weighted imaging. You keep losing background signal. So unless you have a very good scanner, the higher you go, the less information you actually get. So on our machine, I say that B1400 is a perfectly good signal. It gives me good signal, good anatomical information, and it also allows me to detect lesions. And then the ADC map, I assume everybody knows it's a derivative image from the diffusion-weighted sequence. So the ADC map is also looked at. So diffusion-weighted imaging, ADC map, and then dynamic post-contrast sequences. Okay. अब ये note करें, DCE is actually, it is a T1 weighted image. ये top image और ये bottom एक ही चीज, except that the fat is suppressed. So that fat resides in the subcutaneous tissues everywhere. Okay, this white bits. Then you've got the bones, the marrow, inside the femoral heads and necks. That's all fat. Okay, so you can see the fat suppressed image. Actually, all of this is black. Bones are black, right? And the subcutaneous tissues are black. So that's how we. So these are the series of images that we look at. Let's start. So I start with this. I'll start with a T1 weighted sequence, and I go up and down the prostate gland. And if I see any bright signal, and I want everybody to note this down, bright signal within the prostate gland on pre-contrast baseline T1 weighted images confounds the interpretation, confounds PIRADS scoring of that aid. You do not do PIRADS where you see bright signal either. For example, because usually, especially if somebody's done a biopsy, it is usually recommended that you wait for a few months. If you've already done biopsy on somebody, which you shouldn't do nowadays, but I remember in my Pakistan days, a lot of people would do a biopsy and then refer them for an MR, and that would give us a very confusing, blood-filled process. Your blood products, and they're going to just give you a dark signal on diffusion imaging, and you're going to think it's a PIRADS 4. So if you did not look at a T1 weighted sequence and you call it PIRADS 4, you later pointed out there. So that was actually just hemorrhage. That's why. In this guy's T1 weighted.
Recording in progress.
Sorry. Okay, so once I've done that, then I jump to the ADC map. Okay, ADC map, and I'm not looking at the transitional zone. I'm just looking at the peripheral zone outside. अभी भी किसी को confusion है तो please ask me. Difference between transitional and peripheral zone, but I'll say anyway. ये dark, heterogeneous central gland tissue is all transitional zone. Diffusion-weighted imaging is not designed primarily to look at this in the prostate. It is for the peripheral zone. And you can see the peripheral zone, by and large, has a fairly bland appearance. In this guy, and now this is a slightly difficult case, he does have a lesion here, but I know that, people who are looking at it will say, yaar, ye lesion hai, to ye kyun nahi hai, you see. ये थोड़ा सा diffuse है, मैंने इसको पायराइड्स 2 स्कोर किया, ठीक है. इस लीजन को मैंने पायराइड्स 4 का, somebody else might be less certain about it and they might say यार ये पायराइड्स 3 लग रहा है, I need to look at contrast. Okay, that is a level of variability even experienced radiologists will experience. Okay, मैं समझता हूँ कि अगर मैं इसको पायराइड्स 4 कह रहा हूँ और मेरा कोई कॉलीग है, इवन मेरा ट्रेनी पायराइड्स 3 कह रहा है, मैं I would not criticize. Okay, likewise ये डार्क है, अगर इसको भी वो 3 कह रहा है, I will be, okay, well if you say so, but I think that's pairets, so that's fairly dark. Okay, so now you see it's a little bit of eyeballing, a little bit of subjectivity, and a lot of times, experience tells you. You modify the way you decide which region is 2, which one is 3, and which one is 4 based on, how many cases you've seen, how many surgical correlations you've done. कि पैथोलॉजिस्ट से हमेशा पूछना कि यार बायोप्सी में इधर कैंसर था नहीं था, and that guides you and you evolve over time in how seriously you take lesions. I probably call both of these 4 right now, and then funnily I might now say it's 3. और मुझे अगर सर्जन कहेगा कि डॉक्टर साहब ये आपने बदल दिया अपना ओपिनियन, या आपने क्या की, मैं कहूँगा यार इंट्रा यूजर वेरिएबिलिटी, intra-reader variability. The same reader, you don't need to be ashamed. I'll say, yeah, you're fine. Okay, and if I'm wrong, then I'm wrong. We're humans, we can also make mistakes. So you see, that's the way I approach it. So that's the ADC map. I've shown 2 lesions to you. Funnily, this was the hardest case that came first. But it's a great example for pardon?
So there's a question. Sir, when you showed the multiple images of this examination, sir, somebody is asking which sequence was the 4th one on column?
Fourth sequence on that big template?
Yes, yes.
I'll have to go back to it, but don't worry about it. I'll show it again. Let's और ये post contrast है. Okay, fine. Let's go back to it क्योंकि I think मैंने बताना था. Hang on. Right. Let me just finish what I'm saying. So first one, I've looked at the diffusion weighted imaging. Let's actually. Okay, I have to answer this question before I move on. Must like ये app is so rubbish that it might crash when I try to go back to that first template. But fingers crossed. अब आप चाय पी सकते हैं जिन्होंने पूछा था कि फोर्थ इमेज क्या आंसर क्योंकि ये क्रैश हो गया. Let's open it again. One, two, three, four. ये वाला coronal T2 weighted sequence है. Does that answer your question? और ये ना सब में लिखा हुआ मैंने T1 axial, T2 axial के नीचे जब बाद में आप वीडियो रिव्यू करें you can look at that. T2 sagittal, T2 coronal, TWI, ADC, DCE. R को ignore करें typos DCE. Okay, you can look at this in the slides, etc. Okay, so let's go back to where we were. I was saying that I've just finished looking at the ADC map, and I said that okay, this lesion. Okay, now let me rewind a little bit. So when you are doing PARAT scoring, you actually have to give some information about where the tumor is, where you're seeing the tumor, right? उधर एक image है और बहुत सारे hospitals में actually एक diagram use होता है. ये भी आप recommended diagram है. आप जब practice में जाएं, I highly advise strongly to refer to that diagram. Print out a copy of that diagram, and when you're giving your recommendation to the surgeon, draw on that diagram. So develop a habit of using the diagram I'm about to show you. Okay, ये American College of Radiology ACR PARADS V2. आप गूगल करेंगे PDF फाइल खुलेगी
उसके अंदर ये एक डायग्राम टेम्पलेट उनका रिकमेंडेड है, जो वो कहते हैं कि आप ड्रॉ करें कि ट्यूमर आपको कहाँ कहाँ मिला उसमें. I'm referring to the correct file. राइट, इसकी कॉपी होगी और आप इस पे सर्कल्स ट्रायंगल ड्रॉ करेंगे. राइट लेफ्ट इधर डॉट मारा, उस पे एरो दिया और pyrites 3. इधर डॉट मारा, well, that's from settles on. You're unlikely to find lesions there. Either dot mara, or with that. And how do you do it? You split it up on the so you get a rough, it's a rough approximation. Okay, so you go down and up on the axial view. You get an idea. Okay, yaar, middle mein apex hai ya base hai. Okay, so these are the three bits. It's base, mid, and apex. और ये आपके रेफरेंसेस हैं कि लीजन आपको एमआरआई के किस सीक्वेंस में, किस स्लाइस में नजर आए, आप उसको को-लोकलाइज करेंगे. आई एम नॉट गोइंग टू गो इनटू फर्दर बिकॉज़ आई believe it should be self-explanatory. That all you have to do is when you see the lesion, you draw on this corresponding picture a dot, sort of identifying that lesion, arrow it and give it a pyrites. And if it is, going outside the capsule, then, you mentioned that or, draw on that, and that is the image. So it's acr.org, pyrites v2. So let's say कि ये lesion हमने देखा ये यहाँ पे. This is right at the base, right? You can see that these are the seminal vesicles. ये बहुत poorly, I'm sure ये laptops में I would be surprised कि नजर आए. So don't worry if you can't see it. There's that lesion. I'm thinking, okay, this is pyrites 3. So I put a dot on that picture and I say that's a pyrites 3 lesion. Then I go further down. Now I'm looking at every single image. एक मैं थोड़ा सा sarcasm कहूँगा कि ये भी मैं कहेंगे जी हम एक ही देख लेते हैं सारा कुछ. ट्रेंड था थोड़ा बहुत. Unless you pay एक device के, you have to have a schema, you have to have a way. Okay, I am specifically looking at the peripheral zone, right side up and down. Then I'm specifically looking at the left side up and down. You have to take a lot of time. Some people might get away by saying, oh, yeah. कुछ लोग हैं, I don't know, आपका experience है कि नहीं, some people do this. मैं कहता हूँ कुछ भी नहीं है. But never do that. Okay, you gotta take your time with everything. Otherwise, you'll miss something sitting there. Might miss a lymph node there. Okay. That's it. And then secondly, this lesion is right at the apex of the gland. On the left side, so I'll draw on the picture I showed you, I'll draw a dot about it. And at the same time, I'll make note that, you know what, actually I can see a bit of prostate gland outside those lesions, so these are confined within the organ. I'm not worried about this lesion. I don't care if this lesion shows up on DCE or not, because I'm already this is pyrites 4. To confirm, never. Sometimes I even still call it pyrites 4 if it does not enhance on dynamic post contrast imaging. However, when I go back to this lesion, which I've decided today, I'm going to call a pyrites 3 lesion on the right side at the base of the gland. This is not as dark on HC map as that other lesion I showed you. Therefore, for this lesion, I'm going to refer to the dynamic post contrast sequences. And I'm going to see if there is early enhancement. The key word is early enhancement. Because the whole gland is going to eventually enhance. So, lesion there. Let's see how that is going to happen. So split up करता है.
Recording in progress.
But rest assured, because the prostate is completely black, I'm not worried about the contrast being a trouble. Okay? So I'm going to look for early enhancement. Okay, now this sort of workstation I'm using is not what we use clinically, so it's a bit hard to use, but I'm just demonstrating to you guys how to do it. So just bear with me. Hopefully you'll have a more sophisticated tool to analyze those contrast. And even if not, all you have to do is scroll through the images one series after the next series. DCE, like I said, you acquire a new series every 13 to 20 seconds. On a good scanner, every 13 seconds, you're acquiring. On a not so good scanner, every 18 seconds. Recommendations are British के I think 18 seconds से ज़्यादा delay ना करें because you will miss that early blush of contrast that you're looking for. So if that is also another thing. It's called temporal resolution. You should have a good temporal resolution, which means that your scanner should be capable of acquiring series at a very short interval from from each other. Right, so 13 to 18 seconds delay between series. So you keep looking, you keep scrolling down, and your prostate begins to acquire contrast over time. And you keep an eye on that area of interest, and you see if that blushes or not. So let's demonstrate it. I'm gonna एक app है which tries to do that multi-volume explorer. I'm going to take it to the same level. They should be at the same level, obviously. I'm going to link them so that they scroll together. Okay, fine. Link हो गए. Let's see. ये इस ऐप के अंदर इस सॉफ्टवेयर में गैजेट्स है which allows you to increase the sequence number. You're not gonna see me do it, but I'm gonna now start increasing the sequence number. अब watch करें contrast वाली window को. You see how contrast is now appearing in the arteries? Now, you see how contrast first appears in the transitional zone. That is how it should happen. Transitional zone enhances. Peripheral zone, you can see, is still dark. Some of the vascular structures outside the prostate are enhancing, right? But not the gland itself. You can see a little bit of faint enhancement maybe is beginning to appear. And then you keep going on and on. More enhancement in the transitional zone. Keep going. A little more patchy enhancement has begun to appear in the peripheral zone. But to the end, it never enhanced that much. In some people, the whole gland eventually enhances. In this case, it didn't. So I think what I want to especially emphasize in this DCE series, let's start again. So I'm going to go fast. I'm just going to put it on a cine loop. Let's watch it. You see how the transitional zone is lighting up? See how this is your reference. आपको पता चलता है कि यार phase क्या है, कितने seconds गुजर गए, arteries, roughly 30 seconds span. Femoral vein में अगर contrast आ गया, then you can tell, I'm not exact about these figures, so, maybe 90 seconds or so, and so on and so forth. But interestingly, you will see कि यहाँ पे enhancement नहीं आई. थोड़ी सी blush है bilateral, लेकिन ये कोई bulb नहीं इधर light हुआ. And remember, it has to happen early. In this guy's case, you could argue, यार ये तो बेचारे का peripheral zone end तक enhance नहीं हुआ. So any enhancement I see even at minute 3 is, probably cancerous. I would stop after the first few series. When I see some patchy enhancement appearing, I'll stop looking at DCE because I would not trust it so much. Because cancer, remember, cancerous tissue has poor neovascularization. The arteries, they have bad structure because it's cancer. It's not organized, so they are fairly leaky, and they tend to enhance really quickly. There's a little bit of pathophysiology which is the reason pretty sort of universally among cancerous tissue that they tend to enhance, early, आपको पता है HCC, hepatocellular carcinoma arterialization के लिए known है. You might be, I don't know if all of you know this, but actually, theoretically, all cancers are arterial. It's a little bit of an aside from what we're talking about, but colorectal cancer, renal cancer, their metastases are arterialized lesions. The reason we don't call them arterialized on CT is because, and why we call HCC arterialized is because their arterial blush happens really early during the CT scanning, so that we actually, even on an arterial study, which is done for HCC, we won't see it. They will already be dark because their arterial phase enhancement has already happened 5 seconds before, and that's why HCC. So that was a little bit of an interesting, thing I thought I'd share with you. We see it arterialized, and another thing, HCC इधर मैं चला गया. You must know कि जो arterial phase होती है HCC imaging, it's called late arterial phase, and that is the reason. HCC enhances in the late arterial phase. If you do a very early arterial phase, and you should read more about what is late, what's early. If you do it too early, some other cancer metastasis, neuroendocrine tumor metastasis may start enhancing. So, the thing is that they've got, mal-structured vessel walls, they enhance, and that's why also in prostate cancer, it's the early enhancement and early washout we're looking for. Right. That's it. And let's move down. Okay, so is everybody, I hope, clear that I'm going to label this as PIRATES 3, okay? Because I didn't see any convincing early enhancement. And by early, I mean a little before what I'm showing here. Yeah, somewhere, in the early, it's fine. And again, just time my transitional zone enhancement, when it just begins to appear in the transitional zone. If I don't see enhancement in the lesions, I dismiss them as PIRATES 3. I call them PIRATES 3. Then you move further down a few slices, and then you find that second lesion I mentioned. And guys, you really need workstation grade display monitors to be able to do it. I know, unfortunately, a lot of times हमारे पास वो simple monitors होते थे. We did the best we could do with them. But ideally, radiology के लिए, जो optimum conditions and they demand that you should have workstation grade monitors. अब ये lesion है, इधर मुझे भी trouble हो रही इसको किए हुए contrast. I hope people can see. By the way, are you able to see this lesion? Hello?
Yes, I'm able to see it.
Okay, I'm very happy. क्योंकि बड़ी subtle है, even on my screen, which is thousands of pounds worth monitor to hospital with you for home reporting. It's very so it's good.
There are 3 questions. Would you like to take them now or later?
Pardon?
There are a few questions. Would you like to take them now or later?
Let me just finish. Just give me one more minute. Finish this case. So let's look at this second lesion. I'm just really want to drive home this message, and let me tell you guys, this is not an easy case. You understood as I explained everything. I would think it was a success for me in being able to convey something because this is a difficult case. So if you look carefully at the corresponding site on the left gland apex, and you can see that there is enhancement happening. Now you're kind of reaching. Okay. But I'm saying अगर ये वाला केस है जिसमें बड़ी subtle lesions है और मुझे कोई clinician कहता है कि जी please आप T2-weighted imaging पे और contrast पे diagnose करें तो मैं कहूँगा look guys I can't be very helpful. So T2-weighted imaging and diffusion-weighted imaging are the workhorses of prostate imaging. Diffusion post-contrast imaging is an adjunct to diffusion-weighted imaging for the peripheral zone. Okay. Right.
So the question is transition zone. If there is cancer in transitional zone, and DWI is saying so, we do not need contrast for that. Probably it's not that important to do contrast.
Yeah, it's not part of pyrites. I mean, for example, these are not like laws. These are not perfect rules. You could see early enhancement in the transitional zone in a cancer. लेकिन the question देखिए ये कि अगर आप कहते हैं कि यार मैंने diagnose cancer करना है, पहली बात ये है कि transitional zone में you only use पहली बात okay let's look at this case actually. देखें ये कितने dark blobs है, ये transitional zone है, आप इनको cancer नहीं कह सकते. This is benign BPH. DWI is not very useful. Likewise, it's already enhancing anyway. All of the transitional zone, neither this nor that T2-weighted scan. आप थोड़े disappointed होंगे कि वो भी इतना impressive नहीं, but that's the name of the game. आपने इसी uncertainty को label देना है pyrites. Pyrites is, it's a way to label also your uncertainty. Okay, look, I don't know, therefore it is, pyrites. Please don't go and, report everything pyrites 3 that you don't know. You got to identify where you need to ask for help as well. It should not be used as a crutch. If you think you're not adequately experienced, then ask for help. Somebody with more experience to diagnose those. Right. So we're looking at the transitional zone now, which is what I do anyway. After I went through the peripheral zone and I just demonstrated to you that I looked at the ADC map and I looked at the diffusion post-contrast imaging for the peripheral zone, I'm going to move on to the transitional zone and I'm going to look at the T2-weighted imaging and I'm going to look at the diffusion-weighted imaging. Okay. And just to answer any questions that people might be wondering about, I'll also display some of the ECP dynamic contrast sequence there we go. Okay, so this actually requires experience. This is tricky. Anterior zone lesions are among the more commonly missed lesions because MRI is difficult to interpret. Also, biopsy may be कई दफा miss हो जाती. Also, they are less common. So this is a little bit of a stumbling block for all of us, the imagers, also for pathologists. लेकिन इसमें आप यूं एक rule of thumb develop करें. Let's put up the coronal T2 here and let's have everything at hand. So I hope you can see this bulb. You see this light bulb? ये नीचे जा रहा है और ऊपर जा रहा है. That's my phrase, point of phrase. Light bulb look. ये transitional zone. ये axial transitional, coronal transitional zone, T2-weighted imaging, upper right corner, ADC map, lower left corner, the dynamic post-contrast sequence. Now we're only looking at the transitional zone. We've already marked the two lesions I previously demonstrated within the peripheral zone. Now we moved on. Now this is a very prime example of an otherwise normal looking transitional zone which only has BPH signal inside it. Now BPH has a very textured look. ये beads of string कह रहे हैं, grapes कह रहे हैं, bubbles कह रहे हैं, ये जो bubbly cystic bright spots are scattered throughout the tissue, interspersed with mildly reduced T2 signal intensity. This is a standard appearing, normal appearing BPH.
cancer also has low T2 signal intensity. And you will say, okay, if normal transitional zone, like normal as in only BPH, if your BPH affected transitional zone has lower signal intensity than the surrounding peripheral zone, and cancer also has lower signal intensity, then how do we differentiate between a BPH signal and between cancer signal within the transitional zone? The answer to that question is you look for what is described as the smudged charcoal appearance. And this will take experience, sometimes very easy to pick up, sometimes a bit hard, but the main thing you're looking for is loss of these bubbles. Cancer, the bubbles are gone on that area. It's going to be asymmetrical क्योंकि कुछ लोगों का टिश्यू इतना पैक टिश्यू looks and diffuse. That would be cancer. And obviously, if I was not sure, then I would look here. But remember, like I said before, you must never look at the EDC map first to diagnose transitional zone. Otherwise, you call this cancer, that cancer, that cancer. Unnecessary intervention and so on. Likewise, you can't use DCE because the whole transitional zone is enhanced. And I can go further back and you'll see actually all of it enhances symmetrically early. Okay, so I hope that I've described a little bit about how to use Spire-Eyes classification to pick up lesions. I did not go into much detail of what constitutes a Spire-Eyes 2 lesion. The descriptions are there. But I can just give you a rough idea. Obviously, is that you go with something that's very dark, very large. It's a definite cancer. Something that looks like lines or wedges is non-cancer. Things in between are Spire-Eyes 3 where you scratch your head a little bit. Okay. Any questions?
So, mashallah, we have a very good audience today, around 200 people. So there are a lot of questions being thrown your way.
Okay.
So one of the questions is that a lot of people are just confused in the signals on DW and EDC for a cancer.
Oh yes.
Just if you could summarize them.
Yes, मैं कभी नहीं बोलूँगा इसको. मैं जब Canada गया, I had some of the best teachers, alhamdulillah, when I was training. Dr. Najim, Dr. Zia Faruqi, grateful to those guys. Despite that, ADC पे हम थोड़ी सी effort कर रहे थे. कम से कम मैं नया सीख रहा था diffusion weighted imaging. I completely screwed up my interview. I went to McGill University for an interview. Or the guy showed me, it was a neuroradiology fellowship interview, and the guy showed me diffusion weighted imaging and the ADC map, and I completely gave him the wrong information. And he was just looking at me. Yeah, very confidence, but he doesn't have a clue. Funnily, they still offered me the job. So it's actually not so competitive to get fellowships. Get them. Okay, that I would love to talk about it. Because that's one of the reasons, because I was wrong myself about it, so I would love if I can help others not make the same mistakes in understanding, and also that I sympathize. Yes, I understand if you're confused, it is not easy. और इसके ऊपर तो मेरे पास अपनी presentations और भी हैं जो मैंने अपने इधर students trainees के लिए prepare की हुई हैं. Diffusion weighted imaging, and we can maybe have a session about that at some point. Let's see. So this is the ADC map. But yeah, that said, I think I'll not go into a lot of detail. But I hope whatever I tell you should be quite helpful anyway. But if there is feedback that we need more, and I'm sure there's gonna be, because everybody wants to know more. So I'm happy to have another session about it. Right. So, मसला है कि मेरे पास एक बहुत अच्छा सॉफ्टवेयर नहीं है, so I have to work with what I've got. Ideally, I would like to display, low p-value image on one corner,
intermediate p-value, and then a high p-value, and then compare them side by side. But unfortunately, with what I can tell, and hopefully you will still get it. So, इसका bladder इतना full नहीं है, and bladder is a very good reference when I have another case. Let me switch to another case. उसके ऊपर मैं आपको थोड़ा सा, and that'll be the last case of the day. उसमें मैं आपको central transitional zone cancer एक दिखा दूंगा, और hopefully उसका bladder भी थोड़ा सा full होगा, तो हम उस पर diffusion भी discuss कर लेंगे. Right. ये देखें जी, ये एग्जाम्पल है कैंसर और अब लोग सोच रहे हैं यार ये तो कह रहा था कि DWI का कोई इतना काम नहीं है ट्रांजिशन में, लेकिन इसका बहुत अच्छा दिख रहा है कैंसर DWI actually even better than T2. लेकिन मैंने आपको भी एक केस दिखाया जिसमें सिग्नल था डिफ्यूजन पे एबनॉर्मल, लेकिन वो उसको कैंसर नहीं था. So that's why it's not something you use in every case. In this guy's case, I'm actually very happy to see it, but I should be able to diagnose this cancer purely on T2 anyway. That is the test of a good radiologist. Diffusion no doubt helps immensely, as you can see, but you should be able to ideally pick up the cancer. आपको पिछले केस से थोड़ा याद होगा कि एंटीरियर स्ट्रोमा बैंड की तरह एक आगे एक उसकी लेयर थी prostate. अब ये one of the common things in prostate is that there is so much variability. You need to have gone through hundreds before you can be more confident about reading prostate. So do please go back. You need lots of experience. That is always the thing. You need lots and lots of experience before you can become confident. Or I'm aware that we've got some limitations. How we're training. So what we could do is work with pathologists and surgeons. जो भी बंदा एक्सपर्ट जिसका prostatectomy हो या जिसकी biopsy हो, transrectal ultrasound biopsy हो, always chase up the report and get that kind of complete that feedback loop. Hopefully, if not already, there will be body imaging fellowships होनी चाहिए होंगी. I hope जो बड़े centers हैं उधर जहाँ पे prostate imaging को training मिलती हो. If not, then the way I would recommend is to have a lot of clinical, radiological, pathological correlation. Anyway, so now you see this is the glandular tissue. You see the cystic stuff, bubbly, and then this is dark. This is dark too, but you see it is just that slightly I'm gonna link both of these with a move together alone. If not pyrites 4, you say it's pyrite 3 because you say, okay, it's a bit asymmetric. That is a normal band of anterior fibromuscular stroma on the right side. It's a bit thick, and I'm not seeing those cystic sort of architecture there. So this is pyrite 3. And then you look at the ADC map and you say, okay, yeah, it's a bit low there, convincingly low. So that is how a cancer will look. और इसका cancer पूरा irregular surface तक है, so that's a T3 tumor. ये पूरी prostate की ना anterior surface irregular. Anteriorly, I refrain from saying extracapsular extension because, like I said, there is no capsule anteriorly. So I just say that it's extending outside the contour of the gland anteriorly. It's going into the retropubic space. And like ये पूरा एक goal blob है, ये सारा tumor है. क्योंकि आप देखें, this is what they call the smart charcoal appearance. इधर कोई cysts नहीं है, पीछे cysts हैं. That is the healthy transition zone. And this is cancer, or like ADC bits like very, very dark. So it's a good example. Let's now talk about diffusion weighted imaging and use this example. Okay, he's got good amount of filling of the bladder, so that's good. Now this is, I don't exactly remember which one was, p-values कौन सी हैं इसमें B50 typically होती है, B50 तो जरूर होती है. It's called black blood series, okay? वो बहुत valuable है, वो vascular signal को suppress करती है. That is usually the first series. B0 probably use होती है, but it's nothing different from a fat suppressed T2-weighted image. This one, I'm not sure if it's this one is B0 or B50, but it's a low B value. और मैं quickly scroll up करता हूँ. This is highest. You see how as I increase the gradient strength in diffusion weighted imaging, right? That's the highest P value. There is an overall loss in signal. So that's what happens with this diffusion weighted imaging. दूसरी चीज आप note कर रहे हैं कि as we go up in the value, background healthy tissue का signal drop हो रहा है और cancer का signal bright. That's called diffusion restriction. Can you appreciate that? And the ADC map is actually derived. And now this is the counterintuitive thing about the ADC map. And that is that the bright lesion on the high P value, diffusion weighted image series, is not bright on the ADC map, but dark on the ADC map. So it's the opposite. Okay, so that is the thing that is counterintuitive. लेकिन अगर आप इसकी मैथ के पीछे जाएंगे तो आपको समझ आ जाएगी कि ये क्या है. और मैं बहुत शौकीन हूँ मैथ का, तो मैं वो भी आपको थोड़ी सी दिखा देता हूँ. It's actually not that complicated. क्योंकि जो ADC मैप है ना, वो रेशियो से डिराइव हुआ, वो स्लोप को चेक कर. It is checking the slope of signal loss. Okay, so I hope you can appreciate. अगर आप नजर पेरिफेरी में रखें तो you see ये slope है इसका. It's not, like I said, it's not a great tool. तो मैं arrow जहाँ पे खड़ा करूँगा उधर ये slope बना देगा, right? So let's put it there. So okay, fine. You see this? अब ये पूरा slope बता रहा है कि left पे low P value है और right side पे अगर आप जाएं तो high P value. 1000 तक जा रहा है. I think हमारे scanner की 1400 तक थी. So I don't know, maybe it's cropping the high, or maybe it is a 1000 or whatever. Probably is B. It's probably B50 on the left. Probably the first image is B50, and I suspect maybe in that case, last is 1000. तो ये जो slope है ना, आप देखेंगे left पे बहुत high signal है. फिर जैसे जैसे B value बढ़ी और 1000 की तरफ गई, signal drop हो गया. तो आप देखेंगे ये जो slope है ना, it is actually a steep slope. That is a high ADC map value.
that is the ADC, the apparent diffusion coefficient. जितना steep slope होगा उतना bright ADC map होगा, वो benign lesion होगा. So this is benign. मैंने क्योंकि देखें आप माउस को प्लेस किया हुआ है peripheral zone. अब हम lesion की तरफ आए. अब इसका slope देखना है. Actually, you see that? I hope you can see already कि यार signal intensity 450 है पहले image की और आखिरी image की 300. तो slope इसका बड़ा shallow है. So actually, it's that difference between low B value and the high B value that determines the intensity of the ADC map. Because the slope is so flat, you have a very low ADC map. Or in the benign pair, slope is steep. Okay, 800 to 200 जा रहा है. So it's got a high value. Slope is shallow, 450 to 300. Right? You have numbers y-axis. So essentially, for each pixel, the calculates the slope for every single pixel by looking in success slope. It calculates that, and then it generates that as a visual representation known as the HC map. That's it. Or इसमें just like last parting message here. Okay, you have to be wary of using just these images, just the DW images, because of something known as T2 shine through effect. ये मैं चाहता हूँ कि आप सब जाके पढ़ें T2 shine through effect if you don't already know about it. Which आज मैं सिर्फ इतना कहूँगा कि अगर आपके पास ये region है, आप नजर रखें इस region पे, ये bright है. So you start with a dark lesion. Oh, actually, yeah, I'm not going to go into too much detail. Actually, this is brighter, okay, than this. नजर ये bright आ रहा है, लेकिन ये actually brighter है. हमने slope में देखा इसकी value 450 है, और इधर इसकी value 300. लेकिन surroundings dark हो गई हैं, तो dynamic range की वजह से ये bright दिख रहा है. So if you look at something bright on the high B value image, you still have to look at the ADC map to confirm that it is true diffusion restriction. अगर इधर भी bright है ना, तो that is called T2 shine through effect, and that is an artifact. It is not restricted diffusion. Therefore, the box stops at the ADC. I recommend starting with the DWI images because they have higher spatial resolution, but confirm your findings on the ADC. Also because a lot of times interpretation of the diffusion weighted imaging is not as easy because the signal gradient is not so great, especially in prostate. I sometimes actually do omit them altogether, and that's fine. You can omit them and you can go straight to the ADC. Okay, that's all. My questions are written. That's it.
Sir, there are quite a few questions. So mostly the confusion is about the DWI and ADC imaging. So one of the questions was that the peripheral zone is high on DWI, and as well as the cancer is also high on this image. So how do we differentiate? Another question is, sir, about the abscess. It would also appear, sir, right on DWI images. So how do we differentiate that from cancer?
देखिए एब्सेस की तो बड़ा सिंपल है. एक तो बात है कि एब्सेस के लिए तो आपने ना उसकी वॉल्स देखनी है, बंदे की हिस्ट्री है, ओके, बंदे का फीवर होगा और सारा क्लिनिकल पिक्चर है. दूसरा ये कि एब्सेस का जब आप कॉन्ट्रास्ट एनहांस स्टडी करेंगे ना, तो वो बड़ा क्लियर आपको उसकी वॉल्स और सराउंडिंग टिश्यू में एनहांसमेंट जाती नजर आएगी, और सेंटर में फ्लूइड की तरह डार्क सिग्नल होगा. तो आप उसमें इनको आई एग्री कि एडीसी मैप में एटलीस्ट थ्योरेटिकली यस एब्सेस के अंदर सिग्नल डार्क होता है, लेकिन जो पूरी पिक्चर है वो यूजुअली बड़े क्लियर कट होती है. प्रोस्टैटिक एब्सेस भी जो है ना वो प्रॉब्लम नहीं होती. मेरे पास होंगे कुछ केसेस, अगर मुझे डॉक्टर काजी के थ्रू मैसेज रिमाइंडर भिजवा दें, माइट बी शेयर अ केस और टू फॉर प्रोस्टैटिक एब्सेस. जब आप एक दफा देख लेंगे तो यू प्रोबेबली से वो मुश्किल नहीं डायग्नोस करना. जो बात रही पेरिफेरल जोन डिफ्यूजन वेटेड इमेजिंग की, देखिए मैं एक बात कहूंगा. पहली बात ये कि you do not say, you should not say कि इसका तो डिफ्यूजन वेटेड सिग्नल भी हाई है, एडीसी मैप भी हाई है.
you should be practiced enough to make one interpretation by looking at all of it. Okay, that is the first teaching point. आपने जब भी आया कि यार इधर mild diffusion restriction है, देखिए थोड़ा सा gray है ADC map compared with this, you're right, and that follows what you're saying here on this final image. कि ये bright है और ये healthy tissue dark. I admit कि ये और ये इनमें बहुत ज़्यादा फर्क नहीं. Okay? Whereas when you look at ADC map, ये bright और एक बहुत dark. EDC map is not derived from this one image. It is derived what this bright है तो इसकी restriction इतनी नहीं हुई diffusion. ये अभी bright है or did I say it wrong? Yeah, sorry, I said it wrong. इसकी वजह मैं भी आपको दिखाता हूँ. Let's go through all of them. Let's take this over. इसकी वजह ये है, right? तो आप देखें, अब आप पेरिफेरल जोन को सिर्फ देखें तो आप नोट करेंगे बहुत ब्राइट था शुरू में और जो कैंसर है वो इतना ब्राइट नहीं था टू बिगिन में. एक्चुअली वो डार्क था, राइट? और जैसे जैसे सिग्नल ग्रेडियंट बढ़ता गया वो ब्राइटर हो गया. जो कैंसर है दैट इज नाउ रिलेटिवली ब्राइट कंपेयर्ड विद दैट नॉर्मल हेल्थी पेरिफेरल जोन, राइट? So if you put two and two together, the slope of signal intensity is flatter in the cancer, whereas the slope of signal intensity in the healthy peripheral zone, where the signal is very high in the beginning and very low later on, even so that it was higher than cancer in the beginning, and now it is lower than the cancer signal later on. So the slope is actually quite steep. That's why you're not getting so much restricted diffusion. These areas, you get an even higher ADC map. They can see you get peripheral zone, lateral peripheral zone. Okay, it's saved up. That's why it's appearing even higher. So it's just a slope. It's all a slope. I hope that answered the question.
Anuj, can you unmute yourself and ask your question?
Thank you so much. It was a very nice session. I was just wanted to ask about the significance of involvement of neurovascular bundle that it changes the stage and leads to a conclusion that there is capsular breach. So apart from that, is there any other significance of this finding for clinicians, and what about if it not?
It is. I'm sorry, मुझे नहीं पता. To be honest. लेकिन you know, क्योंकि ये nerves होती है, I think really through sphincter to spline.